Our next speaker is Dr. Mark Jeffrey, who's a medical oncologist I beg your pardon. Our next speaker is Associate Professor Jonathan Loree, who's a medical oncologist at the British Columbia Cancer Centre, who has an interest in GI malignancy. His research focus is translational research and biomarker development in colorectal cancer and neuroendocrine neoplasm, and currently he serves as a co-chair of the colon cancer disease site for the Canadian Cancer Trials Group. I'm delighted to have him talk to us about how the early colorectal cancer trial portfolio of AGITG fits into the international context. Thank you.
Thank you, and thank you for the invitation to be here today. These are my disclosures. I'd first like to acknowledge the land where I live and work, and that's the traditional, ancestral, and unceded territories of the Coastal Salish people, the Musqueam, Squamish, and Tsleil-Waututh people. Thank you for the invitation to be here today and to learn from all the great work that's going on both within the scientific realm as well as really the theme of EDI and inclusivity that's been highlighted here today. I've learned a lot, and it's there's a lot of similarities between our systems and our cultures and the struggles that we have, and hopefully we can all learn from each other. All right, so I've been tasked with the early stage rectal and colon cancer studies. And then potentially, if we get to it, the underarm bowling incident of 1981, which I'm told is a bit of a sore subject. And not sure who won the Australia versus New Zealand debate last night, but we can have a rematch today based on the bowling incident. All right, starting with rectal cancer studies. And so rectal cancer is in a unique space right now because we've had so much change over the past 5 to 10 years in what's available for options. And really, this takes into account a number of the cancer characteristics, but we also have to take into account patient characteristics, and those are super important for thinking about this. And so MDT is really the standard for all early stage rectal cancers. And we heard a little discussion about, should patients be included in MDT, and they're not typically included in the traditional way of having somebody there in person, but I think they are really at the heart of a lot of the discussions we have, at least in our local MDT. And we're often talking about where does this person live, what are their supports like, those types of things when we're thinking about all these different options. And so for each person that might be slightly unique, but from the cancer perspective, the things that we need to think about, so I think about kind of the low risk patient, or the low risk cancer, I should say, the kind of moderate risk and kind of the higher risk. And there's all these different options, and there might be different options that are right for a different patient. But this makes it really hard to think about how do we study rectal cancer because there's been a lot of change. And there's a lot of heterogeneity in the different pathways that you could take to get to the same spot. And so the SPAR study is really looking at this question of trying to deepen the response and increase the chance of patients who are going to be cured of their cancer, but also maybe deepen that chance that you have a complete clinical response and you might get to non-operative management. This is kind of at the heart of adding something to chemoradiotherapy. Here's the study. About 50% of patients are going to have a sustained complete clinical response at 3 years, and the MSK study that we talked a lot about this morning. But I think one of the important things, and I don't want to point fingers at this trial because this is a problem that we struggle with in just about all of the rectal cancer studies that are coming out right now, is how do we interpret the data based on things that have changed over the past number of years, and how do we build trials that stand the test of time? And so we're answering the question not just for today, but the question that we're going to have in 5 or 10 years, because these trials take a long time to do. They're hard. We've had some bigger challenges lately with COVID, but there's challenges always to trial recruitment and to making things effective. In North America, this was a platform study that we had with this same question. Very similar endpoint. It was a surrogate endpoint of tumor regression. It was meant to be something that rolled and continuously was open. And only one arm got off the ground. That was the pembro, capecitabine, and chemoradiotherapy arm. There was no difference in the therapies, and the trial actually ended up closing because accrual was slow, and adding on the arms proved to be more difficult than initially thought. And so this was similar setting, and you're seeing similar struggles in the international setting of getting this going and keeping it going. The other big change that's happened is, what do we do? Is it, where do we put chemotherapy? Are we adding chemotherapy to the neoadjuvant approach? Here we've got options of having induction or consolidation chemotherapy. We talked about a little bit this morning that we have evidence that there might be a better approach if we're thinking about getting a deeper response. Again, there might be patient characteristics that mean you might want to do something different, but we see more patients being TME-free if we do chemoradiotherapy first, followed by consolidation chemotherapy. But we didn't know that when this study started, and there's many other studies that have come out that are in that same space. The Germans had also shown this back in 2019. This isn't just something we're seeing in that one study out of New York. We're seeing this consistently, that you should probably try and bring the radiation earlier in the therapy. The other thing that's changed is radiation really the standard? How do we deal with this big change? And so we talked a little bit about prospect this morning, but the field changes between when we start a study and when we finish. And so that makes it really challenging to know. With the retrospectroscope, it's much easier, but prospectively, that's hard. This was a prospect study, so it was looking at trying to avoid pelvic chemoradiation in some patients, so 6 cycles of FOLFOX, and then allowing radiotherapy if patients didn't have more than a 20% response. Only 9% of patients needed that. Disease-free survival, local regional recurrence, overall survival, all similar between the arms, but quality of life differing. And this is something there's been lots of debate about, big news articles saying we're saving patients from the toxicity of radiotherapy, and kind of, that started a narrative that was quite challenging, I think. But we are moving, I would say, through that, at least in my center, when we have this discussion now. I think it's like the 5 stages of grief. There was anger initially, then there was denial, and now actually the rad-oncs are often coming to me and saying, what do you think about chemotherapy for this patient? Should we be thinking about it here? And we go into the room together sometimes, and we'll do that consult together. And I think that's really the best way. We present the information about both options with the patient there and can have a discussion. It's a 3-way discussion. That's not always possible. Sometimes we actually, in our rectal multidisciplinary clinic that we've been trying to do, we'll have the surgeon there as well, and so everybody's in there in the room. That's really the ideal model, is everybody at the table and being able to bring their perspective and have that discussion together. It takes an openness to think about what might be the challenges for kind of each possible therapy, and then really putting the patient in the position to make the right choice. Prospect really applies to a broad group of patients. This whole group down here in the corner, I mentioned kind of that moderate and higher risk group. I wanted to put this into the context of what else is going on in North America, thinking about those patients who are eligible for SPAR. This is the JANICE trial, so it's enrolled 112 out of 312 patients. It's a phase 2 trial, enrolling patients who have either stage 2 or 3 rectal cancer, and they're randomized to long-course chemoradiotherapy followed by either FOLFOX or FOLFIRINOX. I would say that there's been a very strong adoption in North America of long-course chemorads being kind of the preferred approach, followed by FOLFOX. But then how do we reconcile that with PRODIGE being a really strong evidence base? And so this tries to fill that gap. There is discussion of whether this will be expanded and turned into a phase 3 trial, but that's not happened at this point in time. And the primary endpoint is complete clinical response. If it was a phase 3, I imagine that would have to change in some way, in a meaningful way. That leaves patients, though, who are in the very, very early stage group, the low-risk group, also needing to think about what could we do to improve in that group. From an organ preservation perspective, traditionally we've thought about chemoradiotherapy as a potential option in patients who have a complete response, potentially being on a watch and wait approach or with a local excision of some sort, transanal excision. In Canada and the US, this was a CCD trial, CO28 or NEO, which took this population, 58 patients who were T1 to 3, and gave 3 months of chemotherapy, followed by a restaging. And if patients had a low-risk tumor with a good response, they went on to TEMS or TAMIS resection. And again, if they had a high-risk feature, it was recommended to go on to a TME or surveillance. And so this was thinking about organ preservation. One of the challenges with radiotherapy, chemoradiotherapy being your approach, is we have some of those toxicities we talked about earlier as far as bowel function, sexual function. The wound healing isn't also as good if you're going to do a local excision of sorts. And so these were the outcomes. In the bottom right corner, you can see the protocol specified organ preservation rate, which was 57% and was pretty good. But there were a lot of patients who said, I've had a good outcome. We did the transanal excision. I know there's some risk features, but I want to be watched closely because organ preservation is something that's really important to me. And so we actually have a 79% organ preservation rate because of that. While the protocol needed to say that TME was what we'd standardly recommend, this highlights the importance of building into the trial that option of following patients and considering that patient preference piece of what type of therapy are the patients going to want. And one of the big things here is that functional outcomes were much better. So this is rates of major LARS in the far right corner, and patients on the NEO arm are the dark blue, so you can see much lower rates of bowel dysfunction really after intervention. And so the follow-up study to this is the CO32 trial. This is led by Hagen Kennecke as well as Carl Brown. It's going to be a joint Canada-US trial. This is taking patients in a similar group. It's trying not to overlap with Janus, so it's T1, T2, N0 rectal cancer, and there's a randomization between chemoradiotherapy and that chemo approach that looked quite good in the CO28 trial. And then patients who have a complete clinical response, that's the primary endpoint. They can go on to a watch and wait approach, or transanal excision is what's recommended. But there's a patient preference piece that's going to obviously come into there and that decision making. And then based on that, there might also be, if there's an incomplete response, you'd obviously recommend radical resection if you're not getting that option of a watch and wait. And so this is not opened yet, but should be opening soon. So this kind of fills the stable of early stage rectal cancer for the North American cooperative groups. We've got Janus and then the Neo-RT group. So we have tons of great data that's new, but our big issue is how to piece this all together and really thinking of it more like a jigsaw puzzle before we can even get to the choosing your own adventure. The Reno study generates some really important data thinking about what do we do in the real world for a watch and wait approach. There's a really nice patient survey led by Aaron Kennedy that looks at what are you willing to sacrifice as far as outcomes to avoid a stoma for patients who are needing an APR. And it's a 20% reduction in overall survival to avoid a stoma. That's the acceptable rate in this patient survey, which is huge. It's really important for us to ask the question and hear what are your priorities in thinking about decision making. I like Reno as thinking about it as a way of study that's capacity building and really translating knowledge into the clinic. This allows watch and wait in a safe way, gives a regimented guideline for clinicians who might not have experience for watch and wait, depending on your center. I think the one question I ask is kind of, are there any opportunities to add additional questions to this? Or is this maybe preliminary data that might be useful for the next set of studies? And it sounds like there's some really nice correlatives that are already being banked and planned, and maybe that leads to the next study. All right, moving into the colon cancer studies. So for the NeoPol study, this is looking at the vaccine in operable MSI-high colon cancer. You've seen many of these slides from this morning, so I'm going to pass through them early, but quickly. The dostarlimab study was really exciting, but it was 12 patients, and on the initial report, median follow-up was pretty short. And even when we hear the update today, it's 38 patients, and follow-up is really not that long. 24 months, I think, was the median follow-up we heard this morning. And for localized rectal cancer studies, 3-year DFS has really been a benchmark for all of those, like the CART study and many of the other chemoradiotherapy studies. So I think it is still early, but it's exciting. And how do we put this into practice? We've had not just that dostarlimab study. There's Niche 2, which was looking at nivo and ipi in colon cancer. Amazing waterfall plot. Very nice waterfall that we would all like to see in any trial that we're launching, right? It's nice to be able to stand up in front of people with that. The Niche 3 was looking at kind of the next step, adding in a LAG-3 monoclonal antibody as well. Again, very nice waterfall plot that we'd all be very happy with. The industry-led registrational studies in this space, so the rectal cancer study is a single-arm dostarlimab study, about 100 patients, that's AZUR-1, and AZUR-2 is the colon cancer study. This one's big, 711 patients, and it does have a randomization in there, so it's kind of a Foxtrot-esque type comparison, that versus dostarlimab therapy. It's going to take a while to get that answer, and I think it puts us in a hard space when we're talking about what to do, and we've already seen that in the debate today of what do we do and what's ethical to do. NCCN has updated their guidelines and said this is a potential standard option for patients. Are we really there? It's hard, to not call this a standard when you've got a patient in front of you that says, well, what should I do? And think about how exciting it is. I think one thing that we heard yesterday, I feel bad going after Dr. Schultz because he's just so articulate and had such good things to say. One thing he said was it's hard to do a trial if you offer the standard of care off trial. I think that's kind of where we're going to be at, and it's going to be very challenging to think about these studies. So how much evidence is going to be enough for us to adapt this? And can we think about pre-plant pooling and thinking about what we're going to accept? And there might be something that we're comfortable with, but I guess the other question is what are reimbursement agencies going to be okay with? And we probably have to have that discussion very, very early on because single-arm studies don't sit well in health technology assessments, right? We need to not just show that these drugs are effective, we need to get them reimbursed. Dynamic 3. Okay, so what's the state of ctDNA? In the US, Medicare and Medicaid has allowed this to be reimbursed based on a retrospective study that's under 200 patients, which is challenging and certainly not what most of our countries would allow. In Canada, there's UserPay, Signatera, and the Garden MRD assay, which has recently changed to the Infinity platform. That is available by UserPay. I would say it's not really adopted. Most people aren't using it. What do we have for trials? So we participated in Dynamic 3. Thank you for allowing us to join you. That was a great trial to be a part of, really exciting, and helped build, I think, a lot of enthusiasm for ctDNA in the clinic. We also had COBRA open at the same time, which was a study in North America looking at stage 2 colon cancer. And what you'll see is patients were randomized 1-to-1 to receive either standard of care or ctDNA-guided therapy. The group included with this was low-risk stage 2, so T3N0, proficient MMR, and the standard of care was suggested to be no adjuvant chemotherapy for those who were just in that arm. For the ctDNA informed, it's basically if you're positive, you get FOLFOX for 6 months. If you're negative, you get observation. One of the challenges is that this closed, though. So this went to an interim analysis, and we ended up closing it because there were apparently too many false positives. Now, we don't have much detail on that. That's going to come out at GI ASCO. We're going to get a lot more information. Partway through the trial, when you think about when this trial started, that was probably 5 years ago. Technology continually changes, and even if you thought about the assay that was used in Dynamic 3, it might not be the same assay at the end of the trial as at the beginning of the trial that you want to think about using if you're moving something forward. How do we make trials that are future-proof? Again, we're seeing a similar theme to these rectal cancer studies. We need to think about that and think about it hard. I think COBRA is tough because it falls within the NCI purview, and if we got asked to change a therapy partway through a trial, that would be really can't do that, right, from a clinical trial methodology. But technology, do we have a different rule for technology? I don't know. But we're going to need to think about that because these technologies are changing so much. This is the trial that we have replacing Dynamic 3 is open in Canada and the US. So it's Circulate North America. Every patient gets the ctDNA assay. It includes all high-risk stage 2 and stage 3. And once they get the result, they funnel down into the randomization that you can see in the middle level there. So if they're ctDNA negative, it's CAPOX or FOLFOX for the duration that would be recommended by per physician and patient discussion. And then if they're randomized to surveillance to no adjuvant therapy, it's not even a de-escalation, it's no adjuvant therapy. So surveillance with serial ctDNA. If you have ctDNA detected and there's no cancer seen on a CT scan that would happen at that same time, then you can cross over and go into the ctDNA positive arm. And that group would receive either 6 months of CAPOX or FOLFOX, or the comparison is to FOLFOXIRI. All right, so that's our ctDNA portfolio in North America. And moving into the aspirin study, ASCOLD. So you saw the schema just now. This was a trial that was not positive, but we do see the lines separate a little bit. It's a common theme. We've seen that aspirin and targeting this pathway is something that has efficacy if we think about hereditary cancers and polyposis syndromes, and it can be preventative in those settings. What about in patients who've had a cancer diagnosis? Here we're seeing another negative study. This is the 80702 study. This was the North American contribution to IDEA. So many of the IDEA collaboration studies had a second question and a second randomization. Ours was a 2x2 randomization, and so it was to celecoxib or placebo once that 3 versus 6 question was done. This was a negative study as well. You see the same kind of pattern where the curves kind of minimally split apart. And I think we'll have to think about how do we pool all these together, and that was already the discussion we saw in your study as well. And so hopefully we can think about, these are one of those interventions that are ideally cheap and low impact from a financial perspective, and so maybe they have a different value. When we talked about that value equation yesterday in Dr. Salt's presentation, so maybe we need to think about these if we have a pooling, because an aspirin a day is much different than a year of pembrolizumab or something like that. All right, so we've gone through everything. I'm probably going to skip the underarm bowling incident of 1981 since I don't know enough. But one of the things I was tasked with was thinking about potential opportunities for collaboration and gaps. I think you have a really great lineup of studies. A few potential spaces that I wonder about is kind of what's the role of TEMS and TAMIS in very early stage cancer in Australia and New Zealand, and Is that maybe a space to think about a different trial or a collaboration? Is ctDNA in a watch and wait approach for rectal cancers? Is that really setting the bar too high for the assay at this point? When are we going to be there? Maybe that we'll have some nice data from the Reno study looking at that. But I think we've got to start thinking about what's the next question and what's going to be the question in 5 to 10 years for this population where organ preservation is a new goal, but we still want to focus on curing patients. And in the colon cancer setting, I think it's a very nice portfolio. Jenny, I have to say, I put this in here before we discussed the liver study last night, and to Amitesh, thanks for coming up and asking about the detective study again. So this was a concept that we had floated between Canada, Australia, New Zealand, France, EORTC, which is Europe, looking at trying to use ctDNA after resection of liver metastases. So that's a question that comes up in the clinic all the time, right? Do you give chemo around resection of that liver met perioperative, whether it's a sandwich or postoperative? We've had negative trials, but we vote with our feet, and many of us still give chemotherapy in that setting, and so perfect spot for a decision aid. We weren't successful in this major grant that we applied to, and we've had a number of different iterations, but I'm excited to hear that there's excitement about doing this, something new, and trying to refresh this, so look forward to potentially working with all of y'all on that. So with that, I'll say thank you for your time, thanks for your hospitality, and happy to take any questions.
Thanks very much for a very comprehensive overview of the early GI trials in AGITG. Yeah, I don't think there's just one question for this session. The question is, I think the surgical audience is very interested in a TEM study. I'm not sure if that's whether or not, I think they may be asking whether there are opportunities for collaboration, I think. Yeah.
I'm sure there'd be lots of opportunities for collaboration and thinking about trying to fill that gap and thinking about how do we best position this. Organ preservation is it's very patient-centric, and it's where we're kind of moving towards. And I think it kind of, TEMS kind of falls in this like 0.5 range from when we think about a TME with whatever it is, LAR or APR, and then we think about watch and wait. You've got some patients where there might still be something, and maybe you don't need the big surgery right up front. And I think there's lots of questions that we could hopefully help brainstorm and think about. And it's a hard group to apply ctDNA because these tumors are so small, but obviously that would also be a great decision aid of what do you do when you've got just a little bit of something there. Going to an APR is a big deal if this tumor is near the sphincter, and maybe there's some question we can think of together.
I think we just have time for one last question, and I open that to any of members on the panel. There's a question to comment on how do we future-proof our trials in terms of, running tests and assays and collecting and retaining biospecimen to allow validation of new assays that may come on board after the study finishes. Yeah. So any member of the panel can comment.
My philosophy is bank as much as you can get. I don't think there is, if you're going to collect tissue or blood, do use what is necessary for the trial and then bank the rest. There's always opportunity in the future. As you say, with new technology, new biomarker coming, these samples are so precious. You don't want to recollect them again and spend another 5 to 10 years. So bank as much as you can afford to.
Thanks, Jeannie. I'm just interested to hear Jeff's view from the consumer perspective in terms of collecting extra samples, whether that's, serum, blood, urine, or tumor sample. How does it sit with the consumer?
Well, I think it's very much focused on the background, the religious situation of the patient, which obviously needs to be taken into account. But I would think that if you can collect for any future requirements at the time, it's less invasive for the patient and probably more productive for the patient as well with treatment.
Thanks very much, Jeff. I'd like to just thank our whole panel of speakers in the session. Before we go to awards, if you just join me and put your hands together to thank our speakers.